because we're governed not only by our own jurisdictional regulations, but also the national ones as well. But the definition of e-prescriptions have sort of been a little bit up in the air, and we're still trying to work through figuring out the actual what it all means. But my understanding is the road that we're going down is actually that e-prescriptions will be something that will be prescribed into an electronic health record rather than the transfer of the data directly from the physician to the pharmacist as such. It will go into more of the cloud,
Yeah.
and then be downloaded from the cloud to the pharmacy itself.
So that's kind of the model we should use. Submit the prescription into
EHR.
an EHR,
Yeah.
either distributed or central repository, whatever the model is.
Yeah.
And then the pharmacy can retrieve it from that.
Yeah. And right now, like I said, in our structure, the pharmacy system is the repository that will go into. It's what we call our DIS, which is our drug information system. There's different repositories within the electronic health record. We've got LIS, which is our lab information system. We've got the DIS. We've got shared health record. Plus, we've got like our PACS and digital imaging system. So that prescription would actually go into that DIS component and be transmitted back out through messaging as well to the pharmacy. Yeah.
All right, thanks. And the medical record and electronic health record is a similar concept?
When you say medical record, you mean the electronic medical record?
Yeah.
The electronic medical record is more of a system that's used to manage an actual practice. So that information isn't really shared outside of the practice. Whereas the EHR, the electronic health record, is meant to be a global type system that anybody can sort of plug into, and if they're not sending information to that system, they can actually digest the information from
By
it.
anybody means a physician, pharmacist?
Any healthcare provider that's been granted access to the system. It's based on, like I said, a role-based access. And so if you're a pharmacist, physician, nurse practitioner, those are the ones that we sort of have. And dentists, for example, are sort of approved right now as people who would digest the information from the electronic health record. Other people that would request access, it would be sort of reviewed at the time to say, are you part of the patient's circle of care? And if you are, then yes, you can grant access. And you can grant access to different components of it and narrow down the information that could be available to them. But yeah, so it's like I said, it's a role-based system whereby if you need to have access to that patient's information to provide care to them, then you'll be granted access.
Pardon, sorry.
Yep.
So when you say that the idea is to integrate e-prescription into EHR and EMR systems,
Yeah.
so does CIHI provide any regulations, guidelines or standards or any kind of assistance for there's a standard procedure for doing that?
Just trying to understand your question a bit more there now, but I suppose just to backtrack, like I said, the EMR really right now was the system that we were looking at as our place where physicians would actually e-prescribe.
Okay.
Like I said, right now we've only got like a small percentage of physicians that actually have that.
Kunal was kind of getting at, are there standards documents that the team could look at that would define what the structure of an EMR was? Right?
Or the mechanism involved?
In
Is there
regards to
any-
EMR, I'm not sure how much documentation we have around that right yet from the
okay.
center's perspective, because we are in the process right now of submitting an RFP out to the community to look at the vendor, the EMR vendors to review, so that they can submit their request to say we want to be one of the preferred EMR vendors for physicians within the province.
So really the project we're pretending to be
Yeah.
might be in the position of wanting to be certified as one of those. If we were really doing it, we might be in the position of wanting to be certified as one of those preferred vendors.
Yes. Now, I'm not sure, like from what I've heard so far, it seems like you're looking at just the e-prescribing piece.
Right.
The EMR products actually are more than that. They actually provide a way that physicians can document their encounter with the patient, any information that was captured from the patient.
Presumably, we'd have to connect with, if we were to do this realistically,
Yeah.
we'd have to connect to one of those larger systems.
Yes.
Yeah.
Yeah. Yeah. Yeah.
I did a bit of research and I've heard that there used to be, or there are still some standalone e-prescription systems.
There are, there are outside of Newfoundland. I've heard of like Allscripts, which is a program that I know it's widely used in the US. I
Yeah.
think that
Yes,
actually
yes.
is more of just an e-prescribing product.
Okay.
So it doesn't actually provide that comprehensive product for a physician, but it allows clinicians to be able to easily e-prescribe. And then, again, from what I understand, with Allscripts as one example, that is a system that goes to a central repository again, and then it's digested by the NUL, right? So, yeah.
So when we say, I mean, it's a standalone prescription system.
Yeah.
So does that mean that this system is not integrated into any existing EHR or EMR?
I think I don't think those ones are. Like,
Yeah.
this cloud that they have within their structure, I don't think is considered an actual electronic health record. It's just a repository whereby the e-prescription information can be saved and then transmitted on to a pharmacy. So it's sort of a holding place, but it's not really as robust as an electronic health record would be.
So the scope will be limited to a local clinic, maybe not, I mean, for example, the data for prescribing medicines would be a small repository or a database.
Yes, yeah.
And so the scope won't be that wide.
No, that's from what I understand from those particular systems. And that's why, like I said, from our perspective, we're looking broader than that.
Yeah.
So we're looking at that electronic medical record that a physician could use so they can actually maintain all of their other records electronically within their systems, but still be able to transmit their prescriptions to us. And then from there, it can be taken down by the pharmacies as well from the cloud. So,
Sure.
yeah.
So as far as Newfoundland is concerned, what role does the pharmacy network play in this whole process?
Right now, the pharmacy network provides that repository where those prescriptions will be sent and stored until the pharmacy is ready to fill them, process them.
So in this role of the pharmacy network, what part does the physician or the doctor plays? Does he has any concern, the doctor?
Well, once everything is tied together, like I said, the physician can also digest the information that's actually housed within that drug information system so that they can make clinical decisions based on it. Because like I said, those prescriptions are sort of sent there for storage and they can be filled from there, but the actual information is still maintained within that information. And there are query messages that the end users, like nurses and physicians, can use to actually query information about the patient. And it's usually medication profile information that would come from the drug information system.
So we can say that the pharmacy network is the EHR or?
It's a component of the
Component
electronic
of.
health record. Yeah.
Alright.
Yeah, because like I said, we sort of think about the electronic health record as more than just the drug information about the patient. It's also that lab information that's contained within the hospitals about your patients. It's the radiology reports, it's discharge reports that when a patient is actually admitted to hospital and then goes home again, there are reports that are created that are going to be saved within this as well. So it's more of a communication tool between your different health professionals.
Sir, I have a question with you, sir. That a physician writes a prescription,
Yeah.
but for example, if dosage is not correct, what is the responsibility of pharmacist? Does he warn the patient about the side effects of the drug and let the patient go, or can he rewrite the new prescription, or he must have to consult the doctor?
It depends. We've got a couple of different situations here currently in Newfoundland. We've got a process called medication management whereby, depending on what the issue may be, the pharmacist does have the ability to modify the information that the physician has sent through. But if it is like a drug interaction that may
Yeah.
cause harm to the patient,
Okay.
that's usually something that the pharmacist will consult with the physician about to say, do you still wanna continue with this? Or do
Okay.
you wanna change it to something different?
Okay.
So there's different,
Okay.
depending on the situation,
Okay.
there's usually either a communication between the pharmacist and the physician to make
And the
changes.
prescription is updated in the database as well.
Pardon?
New prescription is updated in the cloud as well.
Depends, like I said, if it's a drastic change,
Okay.
the process may be that the old prescription may be what we call discontinued or stopped, so they'll give it a status of, a stop status or an aborted status within the system,
Okay.
and then they'll create a new one.
Okay.
Or if it's something minor, you
Okay.
may be able to modify it
Okay.
using messaging versus having to start from scratch, so.
Okay, there are a lot of insurance claims regarding the medicines. So who fill out the claims for the patients? Is
There's two different, well, I heard you guys talking about it when I walked in the room
Okay.
about the messaging, about HL7. So
Yeah.
HL7 is a version 3 messaging system that we use for
Okay.
the clinical claims, or
Okay.
as we call them. So all the clinical information is sent through that messaging.
Okay.
There's also a less robust messaging system that's used for financial adjudication.
Okay.
And right now it's called CPHA version 3.
Okay.
So extending on that,
Yeah.
HL7 is
Means
so.
pharmacists are responsible for claim any type of claims.
They usually send them through,
Okay.
right? And if it's financial, they're the ones that are going to, as a business owner,
Okay.
they're going to want to make sure that that message is received and processed properly, otherwise payment is not going to be received. So with regards to the clinical information now, they are also responsible for making sure that they get a message back to say that the clinical information was
But
received.
new question, sir. Now, this happens many times if the doctor writes a prescription to the pharmacist. But it happens many times that those drugs are not available in the store. So is pharmacist authorized to give alternate medicines, or he have to consult the doctor?
Again, it depends.
Depends.
There's certain situations where they can modify it and they can change it to something else.
Okay.
And there's other times where they may have to
Okay.
call the physician and change it with the physician's consent.
Okay.
Yeah, so there's two different processes there in place,
Okay.
yeah.
Um,
And again, like I said, with regards to that information, it's sort of housed within that repository. If one pharmacy doesn't actually carry that particular medicine,
Okay.
then that patient has the right to go to another pharmacy if they wish.
Okay.
So therefore, that's why this cloud type system would work better, because the patient always has the right to go to whatever pharmacy they wish. Whereas if you have system to system communication, you're sort of saying that, okay, this physician is prescribing this drug and it's going to pharmacy X.
Okay.
And if it's not being in a cloud anywhere, then the only people that have access to that information is that pharmacy, and that's not how standards are set around pharmacy practice in Newfoundland in particular. And I think it's pretty well the same in most provinces in Canada as well. Yeah.
So extending on the HL7.
Yeah.
So just a very basic question: what role does HL7 play, or what is HL7 in context of the whole health information? I mean.
Well, what we've done as part of the electronic health record development is that we've actually worked with those HL7 messaging, and as I mentioned earlier, we do have a data quality and standards division as well, and those are the people that actually monitor changes to the standards, if to see how things might change within those. When we started out, basically we created a document that was called a vendor implementation standard. We just call it a VIS for short. And what that document is, it's a set of standards or specifications that the vendor has to follow to develop their product to connect to the electronic health record. So all of the specifications around the HL7v3 messaging is contained within that document, which the vendor actually receives from us.
So if we develop a e-prescribing software,
Yeah.
we have to comply by that document. If I am.
I would think that yes,
Yes.
that if you want that to speak to our system, then you would have to probably have that document to actually follow the specifications. It's not necessarily just messaging specifications either.
Yep.
It's a lot of technical and
Mhm.
architectural standards that are set out within that document as well around the transmission of the information over the, the wires and down the pipes. So all that stuff is actually set out within that document as well.
So what was the name of the document again?
It's called a vendor implementation standard.
Vendor implementation standards.
Yeah, yeah. So it's got a number of different volumes to it that we use, and some of the volumes are actually more business related, where
Mhm.
others are more technical and architecturally designed, right? So it specifies all of the modes of transmission of the information over those lines and what you had to follow from a privacy and security perspective, and yeah,
Fine.
yeah. So that might be something that you guys might want
Yeah.
to look at if you're actually looking at developing something for Newfoundland. That would be specific to Newfoundland. There are
Mhm.
the same document is actually created in most other provinces as well, and they set out their own specifications
Mhm.
to connect to their drug information system, because there's different vendors that are providing the back end drug information system in different provinces.
Mhm.
But like I said, every province in Canada, I shouldn't say every province, but most are following that HL7V3 messaging standard, so,
Fine.
yeah.
Another question, one prescription can lead to more than one dispense action. So
Yeah, depends on what you refer to as a prescription. Some people refer to that piece of paper in the old world as prescription. But if there are multiple items within it,
yeah.
then really from an electronic perspective, each one of those items is really considered a prescription.
Okay.
So a physician would always use their physician pad, we used to call it, just that square piece of paper. If there are 3 or 4 items on that, like in the older manual system of paper-based, they may refer to that as a prescription. But really, in the electronic realm, each item that's on there is really considered an individual prescription.
So I have an example here of
Yep.
a prescription. Okay. Good to know. The doctor might want to like prescribe multiple medications for
Yep.
like one condition.
Yep.
So it still becomes a separate prescription. Each item becomes a separate prescription in that case as well.
Yeah, like I said, from the electronic health record perspective, each of those items is actually considered a separate prescription. It would actually, in our system, be given its own, what we call prescription number. So that's the identification number within the system that says that this belongs to this patient.
Okay.
So, like in this particular case here, this looks like what I would call like a compound, which is a mixture of items that are going together into one product. I would consider this one prescription, right? But if this patient was actually receiving these items individually, then that would be considered probably 4 different prescriptions. And they would
So-
all be given their own identifier
So
within the system.
basically, repeat dispense does not require a repeat prescription.
No, like there's two concepts that we use within pharmacy, and there's actually the prescription and the dispense. And you can have a prescription that what we say they have refills on it. So the patient actually has a year's supply of the medication that's been written by the physician, but it's meant to be prescribed in monthly intervals. So that would be one prescription that may end up having 12 different dispense records associated with it.
Yeah.
So within our system as well, all of those dispenses are all linked back to that original one prescription record. So that's sort of the master record, and then each of the dispense records, they can be slightly different depending on what happens each time. The patient may come in first time and say, I wanna have a month's supply of this. The next time they come back, they say, I'm going away on holidays, I want 2 or 3 months supply. So they're gonna get the same medication, but they'll probably get a different quantity of it on that particular fill. So all of those dispenses lead back to that master record within the
Master.
system. Yeah, it's like the prescription is sort of the master record.
So there will be record for refill drug. It's kind of refilling drug.
It's refilling that same drug, yeah.
Same drug.
Yeah, yeah. So you can't really change, you can't change the drug between fills.
Okay.
You can probably change the brand name we call, which is the company that actually makes it.
Okay.
So if a pharmacy carries one particular brand of a drug one month and then they change to a different company, you can continue to change brands, but the underlying medication cannot change from one fill to another. If it it does, then you have to go back and get a new prescription
New prescription.
for that particular item.
All right.
Yeah.
So you mentioned that the EMR system, which was intended for physicians, is not really used much in Newfoundland right now. Why is that? I mean, what's the reasons?
I think it's just based on probably, at this point in time, more the age of our physician population. The EMR didn't come online really till probably, I'd say probably in the last 10 years. And as you know, like new physicians coming out of school now, and any students that are coming, are much more in tune with the electronic
Yep.
systems. And as new physicians graduate from the medical schools, I think they'll embrace the electronic records much more easily. But we still have a lot of physicians that are out there that just don't want to use the electronic systems because they're not comfortable with using them. And the other thing too is I think some of them believe that it's probably going to take them longer to do what they need to do. A lot of physicians, and that's one thing to keep in mind, that if you're actually creating some kind of a program or that for e-prescribing, it has to be something that's very easy to use and very quick.
Yep.
Because the physician can write something down. They need to be able to electronically prescribe it as quickly as they could originally write it. Otherwise, they're going to say, it's taking me longer, I don't really want to do it that way. So it's more of what we call a change management issue. It's changing practice, it's changing how they do that, right? And the other third piece that I think plays a part there as well is the whole privacy and security piece. There still are people who believe that the manual records are more secure than the electronic records, and rightly or wrongly, I don't believe that. Like, I think if you've got the right security and privacy measures in place, you can track people's footprints through an electronic record much more easily than you can in a paper chart. I've seen it from working in the hospitals that the patients' charts sit up in their rooms sometimes, or outside of the rooms in the hospital, and anybody can come by and look at that, and they can view the information that's there, and no one ever knows that because there's no, what we call, footprint left behind. No one knows that they've seen it. But with the electronic system, you have to be able to log in using your own username and password. So once you're in there, any activity that you do is tracked. So I think that's sort of the three things I think that play into why the uptake of electronic systems is slow for
So
uptake.
you must have some experience with existing e-prescribing software, so.
Yeah, I haven't used them personally, but I know I've seen some of them in use, and there's probably 2 or 3 different systems in the province that are actually in use right now.
So in your opinion, what would you consider an efficient e-prescribing system? What key functionalities should an efficient e-prescribing system have?
Well, I think for one thing, you need to be able to search for your drugs that you want to prescribe very easily. In a lot of cases, that means allowing the ability for physicians to have their favorites type lists, so that if they're a particular type of, they could be a specialist, for example, they may prescribe 50 particular medications 90% of the time. So I think in terms of making an electronic system that will work for them, you need to be able to have them easily access those 50 drugs that they prescribe most often, versus having to search a database of, say, 10,000 items that may be in there, right? So it has to be, like I said, easy to search for the drugs and find them. And again, it has to be, I think the format of your electronic pad system would have to be very user-friendly and very easy to fill out. Again, from a physician perspective, I think they want to stay away from codified values and be able to just use free text to be able to prescribe. Doesn't always work that well in electronic systems, because even with regards to HL7 standards, a lot of it is based on standard terminology that you want to use. And but again, it's a matter of how are you going to get the user to use this best. And in some cases, some of the information has to be codified. For example, the drug values have to be codified. And if there is a need to actually codify that information so that you can report on it, then I think in the back end you need to be able to link those free text fields that a physician would be using to a codified value, or use a simple terminology system that they can easily use,
Mhm.
because some of the terminology that's used within HL7 is, and even within the medical world, is very cumbersome. And just an example, I don't know if you guys are familiar with ICD-10, but it's
Just
a
heard of it.
it's a medical dictionary type system that's very structured, and it has thousands and thousands of codes in it. And for a physician to be able to pick from those to use would not work. So
Mhm.
you'd have to be able to use simplified codes that they're familiar with that would link over to those other ones. So you have to provide a mapping type service, I think, for that. So if that's what your product was, if you, and again, that's more so, I think, from a reporting perspective. You're looking to use the information that you've sent in and be able to report on it, to use it for further for, down the road, then that's what you probably have to look at as well. So.
There is a word formulary.
Mm.
Could you please explain? I mean, what is the relation between insurance policy and billing with the formulary? Or
I assume you mean like a drug formulary.
a drug
Yeah,
formulary?
yeah. Basically, it's your drug formulary is your listing of drugs that are sort of on the approved list for use. That varies from payer to payer. Like from our perspective, from an electronic health record, we don't really have the concept of a formulary, because basically any drug that can be prescribed is accessible within our system to be prescribed. Health Canada is the governing body within Canada that actually approves drugs for use in Canada. So
Okay.
we use the Health Canada database as our source of information for drugs.
Okay.
Whereas with the formulary is more uh, synonymous with a financial adjudication system, because uh, each payer that will be paying for the drugs for patients may have their own list of drugs that they are going to pay, and that's what they have on what they call their drug formulary. So the government within Newfoundland has a drug formulary, so they
Yeah.
have a listing of drugs and certain brands of drugs that they will pay for, and if a particular item that's prescribed is not on that list, then they will not pay for it.
Oh, it will free of cost.
No, basically the patient has to pay the cost completely themselves.
Okay.
Yeah, yeah, and
So
that works for all the third-party insurances like your Blue Cross, and there's lots of different payers that are out there. And if it's not on their formulary, then the patient still has the option to take that drug if they want. But if their insurance company does not cover it on that formulary, then they have to pay the cost themselves.
if we produce billing information in this system, then we need to know the insurance plan, whatever insurance plan we have available in Newfoundland.
Yeah. Now again, depending on what you're trying to achieve,
Um,
our electronic health record has nothing to do with financial claims. We don't have any kind of financial data within our
No,
system.
if you want to
I'm
goes to pharmacy, that pharmacy software has to
yeah.
produce billing information,
Right.
right? So
Yeah.
they need this kind of information in
Yeah.
their system.
Yeah. And from the pharmacy system's perspective, the pharmacy vendors provide that.
What's my understanding is that if we develop a e-prescribing software, we shouldn't go into the pharmacy management system. We should just integrate with them, not develop the whole
It's
pharmacy
more
system.
No.
We are
about
doing
the
two
physician,
things:
right?
pharmacy, creating software for pharmacist, and another for
I
prescription.
I think that we shouldn't go into creating softwares
Yeah.
for pharmacy.
Yeah. From what I
Yeah.
understand, you're trying to develop more of an e-prescribed
Yeah.
product, which
Yeah.
really is at the physician level.
Yeah.
Once that information gets into the system, it will move down the line to the pharmacy, but I don't think your product will have to account for that.
So if I just, I mean, if I describe this process in a superficial manner, so what happens is that the doctor or the physician prescribes through this e-prescribing software
Yeah.
and gets the data from an EMR EHR to prescribe. So the software is integrated to that EMR or EHR, and then the pharmacist extracts that information from EMR EHR.
Will come from the EHR.
So
Yeah.
the information goes from the physician through the prescribing software to EMR, then to the pharmacist.
That will be the process, but again, if a physician has an EMR,
Mm-hmm.
then generally that has an e-prescribing
Oh,
functionality within it.
okay.
So I think if you're looking at just an EMR, just an e-prescribing product, you don't really need to integrate with the EMR unless the EMR product is not user-friendly and they want to buy your product as an add-on to make the e-prescribing functionality easier. Right? But generally, all EMR products allow for e-prescribing. So they can actually e-prescribe. Now, in the products that are available now,
Mm-hmm.
it's sort of, they sort of call it e-prescribing, but right now, basically what they do is they're electronically creating the prescription within their product, but they're printing a hard copy, a paper copy, and the paper copy goes to the pharmacy. So it's not a complete electronic transfer of
Yeah.
information. They're just using the electronic
Billing system.
system to
Yeah.
create a paper copy that's easier for pharmacists to read
Yeah.
rather than having to read a physician's handwriting. So it bypasses that barrier, the issues of errors being made in transcription.
Yes.
But the they right now, that's as far as that goes. They print a paper copy goes to the pharmacist. And what we're trying to achieve is to get rid of that paper, and once that electronic information is saved within the EMR, it can be transmitted to the electronic health record, and then the pharmacy
Yeah.
that the patient presents to can actually go into that cloud and pull that information into their system as well.
Also, my understanding
Yeah.
is that pharmacist can also view lab report like X-ray, blood test.
They will eventually, but right now,
Right now,
it's
okay.
not there yet, but that's what the vision is, that there will be a complete record of all patient information. Yeah.
So this all information is tracked through the patient's MCP. I'm just guessing.
Yes, well, that's what we call our the Medicare program within Newfoundland is MCP.
Yeah.
And they provide a unique identification number for each patient.
Mm-hmm.
And that is generally the number that's used in most of our systems to track the patient.
Mm-hmm.
Once that information goes into the electronic health record though,
Mm-hmm.
we have other systems that work in the background that actually create
Another key.
key identifier that ties all that information together. But from the consumer in,
Mm-hmm.
that MCP number is that healthcare number that is used to identify the patient.
So does your EMR or EHR has a e-prescribing software?
Not right now. Now, it's interesting because we actually are looking at, from the center's perspective and from the project side, we're looking at trying to do like an e-prescribing type pilot.
Mm-hmm.
And we're trying to find something right now, some kind of a product that we could use that a physician will be able to easily e-prescribe. We have a product right now which is called, it's an Orion product, which is a company from out west. It's a viewer product only, so it allows for, say, physicians and nurses that work in the hospital to be able to view the data that's in the drug information system, but they can't actually add data through it or
It's just
or
readable.
edit. It's just view only.
Mm-hmm.
So we're using that product right now, and because we're looking at trying to put out some kind of an e-prescribed pilot, outside of having physicians having EMRs in their offices, we're trying to say, well, is there anything else that we could use that could integrate with our viewer that we could actually, a physician could use to actually e-prescribe into our system? And right now, like, there's not really a lot out there.
Well, we can provide you that.
Yeah.
Hopefully.
That, but again, it would be more of an interim step, because once we
Yeah.
get to the point where physicians are on board with EMRs, then
Mhm.
generally the EMR will be the product that will provide that e-prescribing functionality. Right? But right now, I think like I said, in the US market, a
Mhm.
product like your guys are looking at may work better, because I don't fully understand how their system works, but it sounds more like what this all script type product actually does. It's a standalone type e-prescribe package that will allow them to send that information in and be digested without actually having a physician to use a complete electronic medical record.
So again, for example, if you guys are looking for an e-prescribing software,
Yeah.
so would that mean that then that particular software will be totally incorporated into your EMR or EHR?
Well, it would, the information would have to flow in there. Yeah,
Mhm.
so it would have to use either V2 or V3 messaging. Like I mentioned earlier that we do use, our standard really is HL7 V3,
Mhm.
but we do have some interfaces within our system that will allow V2 messaging to be consumed, and the interface will actually take the V2 message and create a V3 message from it that has a lot less data in it, but it will create the V3 message that can come and incorporate into our system. So we still do have a mixture of a bit of V2 and V3 messaging that works, and that's why we have those interfaces in place. But yeah. So in saying that, if there was a product out there right now that could integrate
Mhm.
with our system, that would be something that we would look at as a product in the interim for an e-prescribed type pilot, and for physicians that may not want to uh, get into a full electronic medical record within their office space, then that would provide them an option to be able to e-prescribe without actually using a pad. So not sure how much longer that will last, but
Mhm.
I'm thinking it's probably going to be, I don't know, maybe even 10 or 20 years down the road before we get everybody on board with
Yep.
electronic prescribing. So, but if you could have some kind of a simple product that could integrate into the electronic health record, and that would be easy for physicians to use, it's something that could be offered to them to say, this is,
Well,
instead of having to write prescriptions on paper. The only thing is though, is that if they're using a paper-based system again, then if they're going to e-prescribe into our system in terms of them being able to maintain records for themselves, it may have to have the ability to print a hard copy for their own records until they, like, I know we're trying to get away from paper, and from our perspective, we want it electronically, but if they're not if they're not gonna change over to a complete electronic system, then they may need a way to actually to capture that data manually on paper. So.
So we have a discussion with other physician, and he said that few narcotic drug they don't prescribe electronically. They have to fill up a form to
certain drugs.
prescribe narcotic
That's
drug.
for the narcotic.
Yeah.
Yeah.
So how you, I think there's a term in, I don't know whether US or Canada, they call it shoppers. I mean, they are just looking for banned drugs. I mean, so I guess e-prescribing also helps to deal. For example, you get into that the patient has an MCP, so you know the history whether.
Yeah, yeah, it's what we call double doctoring, and
Uh-huh.
yeah, patients and there are some patients out there who are drug seekers,
Mhm.
and that's the type of products that they're looking for, and in the paper-based system, it's much, much harder to track the abuse that's occurring,
Oh.
because they can go from physician to physician and get the same product, and there's no linkage between those healthcare providers to say that they've already received the same product from another physician. But in an electronic world, it makes it much more difficult, because if you have that single link through that patient's healthcare identifier, then if they get that prescribed by this physician, if they go to another physician and it's electronically prescribed, automatically it's gonna come back, and that alert is gonna be generated to say that that patient had that drug prescribed yesterday, why are you prescribing it again today? So, yeah. But yeah, you're right. That's Gerard Farrell, I think, is the physician who's you're consulting with, and yeah, there's two different types of prescriptions that are written, and everything outside of these narcotic and control drugs can be written on regular prescription pads,
Mhm.
whereas there is a program through government now to monitor the use of these drugs, and they have a special type of prescription pad that monitors them a bit more closely. But in saying that, if we were able to move to an electronic system, I'm not sure if that would actually be required anymore, because you would be able to
Yep.
monitor it in a different way, Right now, it's basically just an interim system that allows you to monitor it because it's on paper.
So you said that a doctor should be able to search drugs when he's prescribing.
Yeah.
So we need to have access with like some drug formulary, as you
Well,
mentioned.
I had mentioned like Health Canada
Health
is
Canada.
the database. They have their own database of drugs.
Can we like can we access it like,
Um,
or we need to pay?
you can get it, like, it is available online, but in terms of being able to access it, to be able to use it within a product, that may be some kind of a license that may have to be gotten from Health Canada. I think we have one with Health Canada, cause we actually, pay, like a maintenance fee every year, and they supply us with the updates to that drug database. And we receive the files electronically, and it updates our database, back at the center. But I think that's something that would, a license that would have to be purchased with Health Canada.
So if we need to make our e-prescription running, I mean, if we get all the implementation done and we need to like deploy it, we need to have this license.
We need
I
to
mean,
catch them.
it will be like.
Yeah, that would make
Almost-
sense to me. Again, you can
Yeah.
probably create your own database of drugs if you wish.
But it needs to be like compatible with the Health Canada database, right?
Yeah,
Yeah.
yeah.
Because your EHR system is using that database as well.
Yes, because every drug within the system has its own identifier. It's
Right.
the DIN number, which is a drug identification number.
It needs to match.
That's the number that's assigned to it by Health Canada, and it's the unique number that differentiates it from all other items. And that's what we use as our identifier.
And in order to like know these identifiers, we need to like get a license from Health Canada. I mean, we
Yeah,
have no other choice.
yeah. Now, there are other databases as well besides Health Canada, because there are some drugs that that are not, they don't fall under the auspices of Health Canada. So we do have some identifiers that we've created ourselves as our own, within our own database. It's minimal as in comparison to the Health Canada, but we call them PINs, or they're product identifying numbers, because they're not necessarily called drugs. They're not considered drugs by Health Canada, but they are products that are prescribed by physicians. So you may not have them in the Health Canada database. So you may have to make, allowances for that as well, to be able to have products in there that physicians want to prescribe that are not part of Health Canada's database.
You guys thinking about wrapping up soon? I know
Yeah.
Saul has
Just
another.
one more.
Okay.
Could you please quickly explain in which condition pharmacist can reject a prescription?
Um, like I said, there's been a recent change in pharmacy over the last couple of years, whereby there are certain products that pharmacists can prescribe, or they can actually take an existing prescription that a physician had written. It sort of expires because they run out of the supply that prescribed. The pharmacist can actually continue the medication for the patient for another month or two, so that there's no break in their treatment. So that's still considered prescribing by the pharmacist, because the prescriber in that case would be the pharmacist, it wouldn't be the physician. So there are certain products, like I said, that a pharmacist can be the prescriber of. It's very limited, but there are some.
Yes.
But then there are certain circumstances whereby products that were originally prescribed by a physician can now be prescribed by the pharmacist, just because the patient needs to continue on for the next month or two. But in that particular instance, the physician still needs to come back into that circle of care and create the prescription the next time around. So it just gives you it's just an interim, step. Yeah.
So last question. You said that primarily we can identify patients by MCP.
Mm.
Is there any other alternative method that we can use? There is a term that I found, pill identification tools. With that tools, could you
Means product
identify patients?
identification number.
What was it again?
Is there any pill identification things that we can use?
Generally, for the patient identifier, it's usually, like I said, that healthcare number.
Yes.
But like I said, other than that, in terms of searches for patients and stuff, but it's a lot, so if you don't have that healthcare number, you can search for the patient by first name, last name, and date of birth are usually the pieces of information that you use. But that's the only unique number that really is out there